The broadcast is now starting. All attendees are in listen-only mode.
Good morning, everyone. My name is Ryan Eborn, and I am here today on behalf of the marketing team with School Health. I'd like to thank you for joining us today and participating in the second of our Ask the Experts webinar series on vision screening. In today's webinar, Dr. Evan Silverstein will talk about the difference between photo screening and visual acuity measurements. He'll also discuss how instrument-based screening is time efficient and, when combined with traditional visual acuity screening, helps identify more children in need of visual intervention. Before I turn the time over to Dr. Silverstein, I would like to review a few quick things about today's webinar. We will not be taking audio questions, but you can submit your questions through the questions interface in GoToWebinar. You can submit your questions anytime during the presentation, and after Dr. Silverstein finishes with his presentation, we will take your questions in the order in which they were received. This webinar will be recorded, and a link to it will be posted on our schoolhealth.com website. We will also email a copy of the webinar recorded link to everyone who has registered for the webinar today. So keep an eye on your email in the coming few days, and we will send out a link for you to watch this recorded webinar. Additionally, everyone who is attending today's webinar will receive a certificate of attendance. You will receive that on the same email that contains the recorded link, and that's going to come out in the days following the webinar. And then lastly, if you are having any technical difficulties with the video portion or the audio portion of today's webinar, we ask that you please give GoToWebinar a call directly, and I've got their number here. It is 855-352-9003. And again, for technical difficulties with audio or visual portions of the webinar, please call GoToWebinar directly, 855-352-9003. And now we'll turn the time over to Dr. Silverstein.
Hello, everybody. My name is Evan Silverstein. I'm a pediatric ophthalmologist at Virginia Commonwealth University in Richmond, Virginia. And I wanted to thank you all for inviting me to talk about vision screening, which is one of my interests, and also it's exciting time to be part of vision screening because of all the instruments that are coming out that will help with the vision screening of the masses and the children to identify problems. Back in the 80s, when I was very young, my mom was my vision screener, and she saw my eyes turning in, which got me into the office of a pediatric ophthalmologist and got me the treatment that I needed, which is also one of the reasons why I became a pediatric ophthalmologist. And so we're going to be talking about vision screening and how we can best screen our children to determine if they need extra help. So first, some disclaimers in my roles. I do serve as a consultant and advisory board member for the Spot Vision Screener, and I'm also a board member of a vision outreach program in Richmond, Virginia. So let's just talk about screening in general first. The World Health Organization put out a 1968 position paper on population-based screening. It identified several factors that we need to look for that would be a disease or a problem that would be excellent for a screening problem. The first is an important health problem with serious consequences that can be identified in a latent or early symptomatic stage. So before it's really an issue, that we can find it and treat. And that goes to the next point of evidence-based treatment is available, and that improves outcomes when started before the disease is symptomatic. The cost of screening should be economical, and screening should be done on an ongoing process with tests suitable for the group being tested. And so vision screening and photo screening really achieves many of the goals that the World Health Organization has talked about. The health problem of decreased vision, and especially in preschool age children, amblyopia, with serious consequences, can be detected quickly and easily using screening methods, and we can treat the diseases or the issues that the children have that are causing decreased vision very well. And so one of the attractive options for screening children's vision is photo screening. It is a quick and easy instrument to use and an easy test to perform. And the vision screener prints out an easy to interpret summary on the screen, and that helps indicate if the child should be referred for a complete eye examination. So this is, again, screening, not examinations. And so looking at photo screening, the American Association of Pediatric Ophthalmology and Strabismus, which is APOS, the American Association of Pediatrics, AAP, and the United States Preventative Service Task Force all looked at photo screening. And they recommended that photo screening can be used for screening children 1 to 3 years of age. APOS and the AAP, the pediatrics and pediatric ophthalmologists, said that this would be recommended for ages 1 to 3, whereas the United States Preventative Service Task Force gave it an I rating, which is indeterminate, which I'll explain in a moment, but that is a good policy to screen children ages 3 to 5, and gave that a B rating, which meant that the task force recommended the service and that there is a high certainty that the net benefit is moderate, or that there is a moderate certainty that the net benefit is moderate to substantial. The reason why they may have given the screening for 1 to 3 years of age an I rating is because they were unsure whether or not treating a child before 3 years of age really made a difference. Versus if you screen them and treated them at 3 years of age. And the ophthalmologist, we do feel like that could make a difference. And then we talk about children greater than 5, which is what we're going to be focusing on today. Historically, we've looked at an eye chart screening, and which is a subjective measurement. And so let's go a little bit more in depth on the types of screening as well, or the age groups of screening. Pediatric ophthalmologists are very focused on preschool age screening, or even before preschool, because we want to identify and treat amblyopia as early as possible. Amblyopia is a decreased best corrected visual acuity in one or both eyes due to a number of issues: a need for glasses, a difference of glasses between the two eyes, a strabismus or eye misalignment, or some type of eye disease like a cataract that's preventing images from getting to the eye. And so the brain turns off that eye, essentially, making it very blurry in that child's vision, even if given the best glasses that are fit there. But the question is, what are we looking for in school-age children? Children greater than 5 or 6 years of age. We still are looking for amblyopia because it has been shown that we can still treat amblyopia for school-age children, especially if they're treatment naive. But we're also looking at visual acuity, how well they can see up close and far away. We want children to be able to focus, to be able to see. And if they need help seeing, then we want to be identifying those children so we can get them the glasses or the correction that they need. So looking back at photo screening, we look at the recommendations from these groups, and we see that children less than 5 or before kindergarten and before, the photo screening is a very validated equipment to use. But the next question is for children that are greater than 5 years of age and school age, what is the best way to perform mass screenings? And so we looked at this question of photo screening versus traditional chart-based screening. And we wanted to figure out whether or not the photo screening is non-inferior to the regular chart-based screening, and also which method is more time efficient. So let's do a little bit more background information as well. What is 20/20 vision? 20/20 vision is if you are 20 feet away, you see what most people see at 20 feet. Then if you look at 20/50 vision, is somebody has to be at 20 feet where the normal population with excellent vision can be at 50 feet. And so you have to be much closer to an object in order to see it. And so 20/50, again, if you were 20/50, you would be the guy in the green jumpsuit here, and everybody else would be in purple, where you have to be much closer in order to see. So let's look at this study that we performed at the Virginia Commonwealth University, where we looked at a single county in Virginia, Chesterfield. We looked at 16 schools where the children were in 3rd grade, age 8 to 9. And we screened all children with both photo screening and the traditional chart-based screening. So every single child got screened with both methods. In Virginia, in public schools, we're required to screen kindergarten, 3rd graders, 7th graders, and 10th graders. And so since the pediatric ophthalmologist group has already suggested that photo screening can be safely used in 5-year-olds or kindergartners, we wanted to go to the next age group. We looked at 3rd graders to see whether or not they could be screened with a photo screener. And so when we look at a photo screener, we get this readout. It does not give us a vision, but it does give us this readout of several different things. So let's look at the numbers that it does give us. The first number right here is the spherical aberration of the eye. What that means is on the picture to your right, I have a red line and a green line in front of the eye or to the left of the eye. And this indicates light coming in horizontally and vertically. And if there's a spherical problem with the eye, then the light is focused not on the back part of the eye. The goal is to always focus light right here on the fovea or the back part of the eye so you get a clear image. But when the image is behind the eye, then we need to bring the image forward or give them hyperopic or far-sighted spectacles. And if the image is in front of the back part of the eye, then we need to push that image back to focus here with some nearsighted spectacles. So the first number kind of tells us where the focus is. The second number is the cylinder correction, which measures astigmatism. And so if there's a high number in that second number, that indicates astigmatism. Astigmatism is an often misunderstood term. It basically means instead of the eye being exactly round like a soccer ball or a basketball, it's a little bit more shaped like a football. And so when you have horizontal light coming in, it can focus in one part. And when you have vertical, it can focus in a different part, thus making the image blurry for the child. And then the third number is the axis of astigmatism, which is basically saying, where does that football lie? Does it go up and down? Is it on an angle? And it gives us a little bit of number of where the astigmatism is. A photo screener can also determine a gaze problem with the eyes, or if there's any strabismus or eye misalignment, if the eye is going up, down, left, right, in or out. This number right here determines if there's a gaze problem or a strabismus problem. And it also gives the size of the pupils, which measures if there's a difference between the two sides of the pupil, sizes of the pupil, which can be clinically relevant as well. So now that we have a background of what vision is and the photo screening and what the photo screener gives us, let's talk a little bit more about our study that we performed. And so when a child is screened in Virginia by a traditional chart-based screen, when their vision is worse than 20/30, they are referred for complete eye exam, or if they're unable to identify the random dot E 4 to 6 times on that screening. Then we also look at photo screening, which measures the difference between the two eyes, the prescription between the two eyes, that is, astigmatism, nearsightedness or myopia, hyperopia or farsightedness, anisocoria, which is the fancy term for a difference of the pupils, or if there is a gaze asymmetry. And so when we're looking at these criteria for a preschool student, where these can be causes of amblyopia or decreased vision, but we also can look at these as indicators of possible blurry vision in school-age children that we can screen for to determine whether or not they are having trouble in school due to their vision and need a complete eye examination. And so if a child was referred by either one of these methods, then we gave them the opportunity to have a complete eye examination. We repeated the vision 10 feet away from the chart, and we gave them an eye drop. The eye drop, you may be familiar when you go to the eye doctor. This is a dilating eye drop. Dilating eye drops make the pupil bigger so we can see inside the eye more easily. But there's a second thing that eye drops do, and that makes vision blurry up close for people. And the reason why that happens is because it paralyzes the muscle in the eye that changes the shape of our natural lens in the eye. Our natural lens can change shapes to bring things in focus up close. And so when we paralyze that muscle in the lens, we can take away that focusing ability, which children do wonderfully well with, but we take that away to allow us to accurately measure their glasses prescription. And we do that with a combination of ways, using what we call a retinoscope, which allows us to objectively measure the glasses prescription for a child. But we also can do a manifest refraction using what's called a phoropter, which you may be familiar with, which is better, 1 or 2? One of your favorite questions. But we can participate, or children can participate in this examination pretty reliably to understand whether or not they need glasses. So when we looked at the children at these schools in Virginia, we screened just under 1,600 children. And of those, we referred 32.4%. Of those children who were referred by the traditional method, it was about 18%, and the photo screening method, 25%. And when we tried to do the exams in school, we got just under 50% of the children who were referred for examination did get a complete eye examination, which is pretty good for a study like this. And looking a little bit more in depth on the children that were referred, I did note that the traditional screen referred 18% and the photo screener referred 25%, but there was some overlap. There were 169 children who were referred by both methods, an additional 230 or 229 students that were referred by the photo screening method, and an additional 118 that were referred by the traditional screen only. So these 229 were not referred by the traditional method. These 118 were not referred by the photo screening method. And so now let's go more in depth on the findings of our study. We looked at the children who had examinations by the ophthalmologist or the optometrist. And there were a similar number from each group that had examinations, the group on the left being those that were referred by the photo screener, and those on the right that were referred by the traditional. When we repeated their vision, we found that a higher percentage of children screened by the traditional method, 75%, did indeed have a visual acuity of less than 20/30, where 70.4% of those that were referred just by the photo screener had a decreased vision, which makes sense because the traditional method is directly measuring vision or screening vision. Then when we look at whether or not glasses were prescribed for these children by the optometrist or the ophthalmologist, a higher percentage received glasses in the photo screening group, a total of 82.2%, whereas a lower percent were prescribed glasses, 73.8%, in the traditional vision screening. When we look for any type of intervention, intervention here is defined as needing glasses or being referred for a more complete eye examination that we couldn't perform in the school. Both percentages went up about the same. We also looked at children who were diagnosed with amblyopia. We had 22 children who were referred by both methods that had amblyopia, but interestingly, 20 more children were referred by the photo screener who had amblyopia than the 4 that were referred by the traditional method. So I'd like to take a moment and just look at the forest through the trees here. Both methods detected a significant number of children who had decreased visual acuity. And like I said, predictably, the traditional screening was correct in identifying these children a little better than the photo screener. The interesting finding here is that the photo screener picked up more children than the traditional vision screen, and a greater number and also a higher percentage of those children needed a intervention. And one of the ways to think about this is, are children faking their way through the visual acuity measurement? Are they looking with one eye, their good eye, and peeking when their bad eye is tested? Are they squinting to provide a pinhole effect, which would improve their vision? Are they listening to the person who was just tested in front of them and measuring, and that was being screened right in front of them and repeating exactly what they heard when it's their turn? I have several ophthalmologist friends who actually utilized this technique and did not get their nearsighted glasses until they were in middle school, when they would have benefited from them in 4th or 5th grade, because they were excellent students and could memorize things very well, and spit back out the answer that their peer gave when it was their time for their screening. One of the fears that I had is what is missed by either one of these groups if you are just doing photo screening or just doing traditional based screening. And so we look at the children that were referred by only one method. We take away the children that were referred by both methods, and we look at the children that were referred by either the traditional group, the chart-based screening, or the photo screening group. There were additional 98 referred by the photo screen versus 54 from the traditional screen. And the intervention of the photo screening that were referred only by the photo screening was 76.5% versus 50% from the traditional screen only needed an intervention. And of those, the non-refractive diagnoses, there were 8 children in the traditional screen and 2 in the photo screen. What I mean by a non-refractive diagnosis is their decreased vision could not be explained just by needing a pair of glasses. And so let's look in depth more with those that were screened and referred just by the photo screener and would have been missed by the traditional screening methods. One of these children, the traditional screen said that they had 20/30 vision in both eyes. They were referred by the photo screener for a difference of glasses prescription. And when they had their initial vision screen on the examination day, their vision was actually 20/70 in both eyes. And they were found to have no significant need for glasses or refractive error. And we couldn't get their vision better with the 4-opter better than 20/70. The examiner noted that the child, quote, wanted glasses and apparently already has glasses at home. And so this type of child was referred for additional examination in an office-based setting to figure out what exactly was going on with that child. Was their vision actually 20/30 and they wanted glasses, or is there something else going on that we can't detect by just measuring for glasses? Then we look at the traditional screen here for the second child. They were also 20/30 in both eyes. They were referred by the photo screener again for anisotropia, or difference of glasses prescription, and also astigmatism. When we measured their glasses or their vision was 20/50 in both eyes. OU means both eyes on their initial vision screen, and then we measured them for glasses. The first number here, again, is the spherical change, the astigmatism, and where the astigmatism is. And so when we measured them for glasses, this prescription gave a vision of 20/30 in the right eye. And this prescription gave a vision of 20/50 in the left eye. And so could this be untreated amblyopia? Ideally, we would think that the vision could be getting better than 20/30. So we couldn't really explain exactly what was going on here, and they needed additional examinations as well. And then we look at the children that were referred by the traditional method. This means that they were missed by the photo screener or had a non-refractive diagnosis. There was no improvement of vision with refraction, and it could not be explained by refraction. Again, refraction means measuring for glasses prescription. These 8 children, you can see their vision are pretty decreased. 2100 means that somebody who has normal vision can be 100 feet away, whereas this child had to be 20 feet away to see it, and 20/70. And you can see the ranges range from 20/70 to 20/50, 20/100, and things like that. We also have some comments from the examiner saying that the child was malingering, where the physician felt like the child could see better, but they were, quote unquote, faking it. Now, are these children actually faking it, or do we just get frustrated because we can't explain it by a need for glasses, and we do a further examination to look a little bit more? So now looking at timing of the exams and which one is more time efficient. The photo screen on average took about 30 seconds per child. That's, setting them up, putting them in the right place, making sure that their information is correct in the photo screener, and taking the picture. Picture itself takes just a few seconds when you're 1 meter away, where the traditional based screening took 120 seconds per child. So it took 4 times as long to screen children with the traditional screen than the photo screen. So what are the conclusions of using a photo screener like the Welsh Allen Spot Vision Screener in a vision screening program for school-age children who theoretically could read an eye chart? The photo screeners are great autorefractors, meaning they are great at picking up needs for glasses. picks up on high astigmatism. There are some children that do have high astigmatism that still can read the 20/30 line on the eye chart, but it is not a clear 20/30. It's a blurry 20/30. And so by giving them a pair of glasses, we give them a very clear 20/20 vision, ideally with a pair of glasses. And so we find that those children do need glasses. Are kids faking their way through vision screens? Are they, like I said, utilizing any of those techniques to pass the test? Whereas a photo screener is an objective measurement, and so you can't fake a objective measurement. And did these children who actually need glasses develop good compensatory abilities when they're screened for vision? Traditional screening does pick up on children with low vision that might not be related to refractive error. And so with those children, they really can't see, and it's not explained for a need for glasses. And that's why teacher and parent input is still essential. If a teacher has a hunch or a parent has a hunch that their child can't see, they should still be referred for an eye examination. And finally, photo screening is 4 times faster than traditional based screening. So the question that I posed initially, can photo screeners be used to screen 3rd grade students? As a screening device, photo screeners work just as well as traditional based screening. And it may even pick up more children who need glasses, with the caveat that it may miss some children who need further examinations, as is with the case with all mass screenings. At this time, I can open up the floor to questions and appreciate your time and attention.
Okay, thank you, Dr. Silverstein, for this wonderful information. This is really, really beneficial, I think, for the audience that we have here today. We do have a number of questions that have come in, so we'll begin to answer those. And I'd just like to remind everyone that if you have a question for Dr. Silverstein, go to the questions interface on GoToWebinar. You can submit your questions there. We also have Mary Ellen from School Health, who is our vision screening specialist. She's very dialed into the concerns and troubles that school nurses, that people in a school-based setting will face during vision screening, and so she may chime in with some answers as well. The first question that I have here asks about a photo screener such as Spot providing a visual acuity result. Does a photo screener provide a visual acuity result?
So unfortunately, photo screeners do not give a visual acuity. It gives a measurement for the need for glasses. There are some tables out there that estimate amount of nearsightedness to a visual acuity on an eye chart, whereas a child that has a prescription of minus 0.50 might be reading on the 20/25 or 20/30 level, and then each line, each addition of half a diopter, half a measurement of nearsightedness makes the vision worse 1 to 2 lines. And so there are some estimate tables out there, but it really does not give a visual acuity at all, but does do a measurement of the need for glasses. It's interesting, though, that some children, especially with low vision from a younger age, will develop a strabismus. And so if they did not have a need for glasses, but there was a decreased vision in one eye, then the photo screener may pick it up under the strabismus instead of a refractive error.
Okay, great, thank you. Another question in here from Kira, asking about, I think the beginning slides that you were showing, Dr. Silverstein. She's asking what chart you used for the traditional screen, and she's wondering if it used World Health Organization International Standards for Design.
That is a good question, and I can't say exactly which screening chart we used, unfortunately, but it was one of the standard eye charts that are used for vision screening.
Okay, thank you. Shanna asks, and I believe I heard you comment on this a little bit, but using photo screeners only for mass screenings. She asks if you're allowed to do that, and I think that the way that you positioned it, as I heard, is, is it wise to do that? So do you want to comment on that?
Yes. So for mass screenings of children, especially in public schools, you have to look to your laws. In Virginia, our laws did not mention anything to do with photo screening, and so we did this study and brought it to our representatives, and they did change some of the requirements for vision screening to allow for photo screening based on these results. And so you have to look at what is acceptable. And so what this is pursuing is, is it wise, as we were saying? And so the conclusions here is that if you do photo screening only in third grade children, you pick up more children who have a potential issue, and more of those children that you refer need glasses. And so with the caveat that you have to look at the child as well and try to understand if they're having any issues from the teachers or the parents' perspective.
Okay, that makes sense. All right, question, comment from Susan. Her district in California, it looks like, is the third largest district. They have 3 photo screeners that are used primarily during mass screening times, and that only gives them access to these screeners 1 or 2 times a year. And she's asking if you recommend that school nurses have access to photo screeners more often during the year, in order to catch students who might miss the mass screenings, students who may have an individualized education plan upcoming, and what your opinion is on having those screeners available more frequently than just during the mass screening.
I think having the vision screeners available just during the mass screening is adequate. Vision screening is a longitudinal process where you do it over time. And once a year should be sufficient, with, again, the same caveat as if you're concerned, if a child has an IEP, if you're concerned about their vision, those children should always be referred for complete eye examination, despite what any vision screener tells you. And so if there are these children that you're worried about, refer them. Don't worry about a photo screener or even a traditional chart-based screen referring the child. Just refer them. The pediatric ophthalmologist or the ophthalmologist or optometrist that you meet with, or that the child meets with, would be happy to evaluate them for any subtle issues that you are concerned about. So a photo screener just during mass screening is perfectly fine. And then if a school nurse is concerned, then I think taking the 120 seconds to check that child's vision in that setting where you are worried is perfectly appropriate as well. Whereas the photo screener is wonderful for the mass screenings of detecting children and more children, and they have a high percentage of needing a intervention.
Okay, thank you. Question here from Karen. Can we review refractive error as compared to visual acuity?
Absolutely. So let me see if I can bring up my slide here. Excuse me. This is a good chart that would clear this up. So on the right is a visual acuity chart, where if they read on a certain line, then you can measure their vision as 20/20 or 20/30, 20/40, etc. Whereas a refractive error is a glasses prescription that would hopefully provide 20/20 vision for the child. So without glasses, they may be reading one of the larger numbers on the eye chart, or visual acuity that has a high second number, 20/100. And a refractive error is why the child can't see. Is it nearsightedness? Is it farsightedness? Is it astigmatism? Is it a combination of the previous, where when you put that into a glasses prescription, then their visual acuity should improve?
Okay, thank you. Question on, let's see, looks like a question from Susan here. Can you give some examples of low vision through chart screening that cannot be picked up by photo screening?
Absolutely. So some of the problems that you may encounter could be some type of scar in the eye, or any disorder to the retina, which is the camera film of the eye. If you think about a camera, where the light comes in through a lens and then it's focused on the camera film, if the film, if there's a disorder of the film, no matter how clear the image that comes in is clear, you're still not going to be able to develop that film because the film is abnormal. So if there's a retinal problem, that could be an issue. If there is an issue in the brain where it's a processing disorder, something called cortical visual impairment or cerebral visual impairment, where there was an injury to the brain, or the child was very premature and had some bleeding and hemorrhages in their brain when they were born. If there's a processing issue that's in the brain, then a photo screener would measure the eye as perfectly normal. And those are the main issues that I see when a child has a vision problem that a photo screener would miss.
Okay, thank you. Let's see. Question from Eva. It says, what is your screening recommendation for identification of students with low vision? What grade levels, for example, would you recommend?
That's a very good question and a difficult one to answer. As a pediatric ophthalmologist, I like to have children be screened, especially when they are less than 7, once a year, because like the United States Preventative Task Force says, you want to be able to identify and treat problems of low vision. And so, because amblyopia, which is the reversible cause of vision loss in children, probably the most common cause of reversible vision loss in children, we can treat much more effectively less than 6. And then we get into the school-age children who likely, hopefully, don't have amblyopia, but they have decreased vision. Low vision is a very broad term as well, and it can be taken to be, low vision that can be corrected with glasses, low vision that cannot be corrected with glasses. And so for screening children, I'm not sure if I can say exactly the grade level, but for mass screenings, probably once every few years in a school-based system would be adequate, because refractive error doesn't change that frequently. And so if we're just picking up, if our one of our main goals is to pick up children with refractive error or a need for glasses, then every few, like probably 2 to 3 years should work just fine, as long as that child does get the serial screening, and that's one of the most important things.
Okay, thank you. All right, I've got a question from Anya, who asks, or who says, we use threshold screening and refer for a 2-line difference. How would you expect using this referral method to change study results or comparison to the photo screener?
So a 2-line difference is indicating amblyopia, meaning one eye does not see as well as the other eye. And the photo screener should be able to pick that up with a measurement of anisometropia, which is the difference of glasses prescription between the 2 eyes, Orst your business. And so I don't think that the photo screener would miss a lot of children who have this issue of two-line difference between the two eyes that was picked up by the chart-based screening.
Okay, thank you. All right, from Lauren. Do you recommend doing both the vision screener and the charts on students over the age of 5?
So the purpose of this study was to understand what we were missing if you picked one or the other. I don't think, and obviously if you do both, you're going to pick up more children. Let me just bring up the numbers here. Oh, sorry, wrong slide. So, you look at this summary of all the information and you get, if you are screening by both methods, then you get to stack everything. You get to add this 32 to this 57, add this to here. I think picking one or the other is a okay thing to do. I do not think you need to do both.
Okay, thank you. All right, let me take a look and see. Sarah is asking about the reliability in regard to students with special needs or students who may have cultural or language barriers.
Photo screeners are awesome for these children. With language barriers, with children who can't participate in a visual acuity measurement, photo screeners are amazing because you don't have to cooperate that much. You have to look at a target for just a few seconds and grab that picture. That's why we can do this in children as young as 1 year of age, and sometimes even 6 months old. You capture their attention, you keep their attention, and you get a measurement. And so with just a few seconds of attention, you can get an accurate measurement of their need for glasses. Now, one of the other audience members said, well, what if it has nothing to do with a need for glasses? What if there's another reason to have decreased vision? Then these children, if the parents or teachers are concerned, should be referred for a full eye examination. But the photo screener is a wonderful way to screen children who cannot reliably participate in a chart-based screen.
Wonderful, thank you. And I'm seeing a couple of other questions here. Monica and Nadine are both sort of asking the same question that we've just talked about, students who are medically complex, who are nonverbal, and it sounds like the photo screener is going to be a good option for all of those situations.
Yes, and then again, parent and teacher concerns about vision. If they're medically complex, then there might be something deeper going on than just a need for glasses. And so if the photo screener passes them, but the child is not participating well, is squinting, turning their head, moving up to the front of the class for clarification, then that child should be referred no matter what as well.
Okay, thank you. All right, let me take a look and see what we've got next here. All right, so Pamela, I'm sorry, Nancy. Bear with me just a minute here while I read through his. All right, Nancy says that she wants to share that her Lions Club in Maine, the members have been trained to do photo screening. They've been working with them for about 3 years now, doing the visual acuity screens as well as the photo screens. And her comment is that they've referred more this year than in years past, and the parents have been amazed as they have sat with children for the screening and then gotten the results of the photo screening right away, showing that they really do need to pass these kids along to an eye care healthcare provider.
And a further comment on that is 50% of the children who were referred got eye examinations in the school. We don't know how many got it outside. The real crucial part of vision screening is when a child is referred that they get to the physician that can treat them. A screening doesn't do anything if you just identify a problem and say they need an eye exam. The eye exam is the part that's really crucial in getting the intervention on the kid's face if they need a pair of glasses. And the photo screeners provide a benefit of hard measurements and big red circles that say refer, refer, refer. Whereas a traditional screen, you might just get a paper that says your child failed an eye screen, their vision was X and Y, and the parent says, yeah, our vision isn't that. They can see just fine. When you get a photo screener that gives discrete data and you get to carry that to the ophthalmologist or optometrist office, then it's another kind of big thing that the parents can see that might encourage them to get that eye examination.
Great, thank you for that comment. Question from Brenda says, can you address the darkened room approach in order to dilate pupils? How dark is necessary, and is it still accurate if you rescreen right away when you get a timeout attempt?
The Welsh Allen folks might be better attuned to this. You do a somewhat darkened room to get the pupils big enough so you can get an accurate measurement. If you're in a very bright room or even outside, the pupils might be too small for a very accurate measurement. And so when you get the timeout or saying, please rescreen, there's no amount of time that you have to wait. You just kind of bring them into a little bit more dimly lit room to see if you can rescreen and try it again. And so when you get that error message, just kind of think about what in the room might be distracting the child, that they're not looking at the device, or if the pupils are just too small, then consider dimming the room lights. And I'm pretty sure you can do it in a completely dark room as well, because it uses infrared technology that you don't even need much of a light in the room in order to get their measurement, and you can follow the eyes on the screen pretty easily.
Okay, wonderful, thank you.
Brian, this is Mary Ellen. I would just add that in regards to this question about rescreening right away, and if the device times out, there's something with children called accommodation, and what happens is these children have the ability to refocus, and so you may get a different reading than you would the first time because of this ability. So it's recommended that we go with the first reading that is taken, and if it times out, you should probably wait to rescreen that child for a good period of time before you go back, so that you can get a more accurate reading.
Wonderful, thanks, Mary Ellen. Okay, it looks like we're coming up on time. I see that we have many questions here that we have not had a chance to get to, so we apologize if we haven't been able to answer your question. Please know that we will put together answers for the questions that we did not have the chance to answer, and we will reach out to you and make sure that we answer your questions for you. Bear with me just a minute here. All right. Want to thank Dr. Silverstein for his time, for his knowledge, and everything that he shared with us during the webinar today. We hope that you found it useful. I also wanted to direct everyone to an offer that we have exclusively from School Health in Welsh Allen. You have the opportunity, if you are interested in a spot vision screener, to save up to $24.25, nearly $2,500 savings when you trade in your old vision screener And in addition, you are able to get a 5-year Partners in Care warranty at no charge to you. And again, this is an exclusive offer that's only available through School Health in partnership with Welsh Allyn. And this 5-year Partners in Care warranty is kind of a big deal because it gives you a lot of really good benefits for your screener and your screening program. For example, if you have a problem with your screener and you drop it, that drop is going to be covered. But as we heard earlier in the presentation, perhaps you're in the middle of a mass screening event. And so what they're going to do is they're going to actually overnight a complimentary loaner to you in addition to covering the drop or accidental damage protection from the screener. With the shipping, everything is covered in full. The parts and labor are covered in full, and you also have access to remote technical support. So really great benefits through that Partners in Care warranty and significant savings when you're trading in an old photo screener toward the purchase of a spot vision screener. And again, this is exclusively through School Health and Welsh Allyn. One final note here, after you exit the webinar, you'll see a survey window. We would ask that each of you please take a moment to fill out this brief survey. It's only about 6 questions long, but it really helps us to let us know, how we've done here today, and if there's things that we could do better. If you have any general feedback for School Health or for Dr. Silverstein, please let us know through that survey. I have also just sent out a link to everyone. It's a savesite.welshallyn.com link, and this link will direct you to the Welsh Allyn site where you can find out more information on the spot vision screener. You can get a copy of this Silverstein study. If you would like to have a copy of that, just click on that link that you'll see in the chat window. Again, it's savesite.welshallyn.com. And that is all the time that we have for today. Again, thank you everyone for joining us. Keep an eye on your email for your certificate and for the recorded link that will be coming in the next few days. And we'll end the presentation now.